In EMS today, there's a steady increase in the percentage of respiratory distress calls. This has driven the need for capnography in the pre-hospital setting. The latest AHA Guidelines 2005 give capnography a Class 2A recommendation, which is considered intervention of choice and standard of care. The American College of Emergency Physicians and the National Association of EMS Physicians have also stressed the use of CO2 monitoring in EMS to verify endotracheal placement. It's becoming a standard of care that all EMS agencies continuously monitor tube position during transport, as this is providing advanced level care for the patient. Proper airway management and end-tidal CO2 monitoring are critical in the pre-hospital environment for verification of tube placement and the effectiveness of CPR. By understanding the benefits of capnography and using this option on your Zoll defibrillator, you'll have an essential piece of information to help assess and optimize your patient's care. This program will review capnography in EMS, mainstream and side stream options, and field applications for both intubated and non-intubated patients. Capnography is the measurement of carbon dioxide in the patient's exhaled breath. Each breath is shown as a CO2 waveform on the monitor. The monitor provides both measurement value and waveform on the same reading. In addition to its use for tube verification, continuous capnography monitoring during patient transport gives you a breath-by-breath status on your patient. It's not uncommon for patients to experience certain adverse events when being transported, such as accidental extubation when being moved from in and out of an ambulance or from the stretcher to the ED bed, which results in the tube being removed from the vocal cords. Capnography can also be used to gauge how effective cardiac compressions are during CPR, as it's an early indicator of return of spontaneous circulation. The better your patient's cardiac output, the higher their EtCO2 readings will be. A normal CO2 is between 33 and 43 millimeters of mercury, and normal arterial CO2 is 35 to 45 millimeters of mercury. The difference between the normal arterial CO2 and the end-tidal CO2 is 2 to 5 millimeters of mercury in a healthy person with normal ventilation and perfusion. This difference increases with low and high ventilation and perfusion. In the patient with poor cardiac output, this will drop to below 20 millimeters of mercury. Capnography is also used to monitor airway obstruction in patients with COPD or asthma. The end-tidal CO2 readings will give you an indication of how mild or severe their symptoms are and how well they respond to treatment. Normal end-tidal CO2 levels are dependent upon the ability of the patient's cardiovascular system to deliver carbon dioxide to the pulmonary circulation system. Any change in circulation will result in changes in the CO2 delivered to the lungs, and this will be shown as a change in the CO2 reading. Physiological factors that can affect CO2 levels are increased cardiac output during resuscitation and effective treatment of bronchospasm. A decrease in end-tidal CO2 can be caused by drugs, cardiac arrest, pulmonary embolism, and bronchospasm. It's important to have a basic understanding of the ventilation-perfusion relationship. With a normal patient, the ventilation-perfusion are matched. Low ventilation perfusion is caused when the alveoli are perfused but not ventilated, as in right side intubation, pulmonary edema, or pneumonia. High ventilation perfusion can be caused by pulmonary embolism, cardiac arrest, hypovolemia, or shock. The normal capnogram is the best available evidence that your patient's ET tube is correctly positioned and that proper ventilation is occurring. Phase 1 occurs as exhalation begins, which is shown as A to B on the capnogram. The first gas to appear at this sampling point is the last gas inhaled into the conducting airways. This gas has not been subjected to gas exchange and is essentially free of carbon dioxide and remains at the zero baseline. Phase 2 is characterized by a rapid rise in CO2 concentration, as any anatomical dead space is replaced with alveolar gas, leading to Phase 3. In Phase 3, all of the gas passing the CO2 sensor is alveolar gas, which causes the capnogram to flatten out. This is called the alveolar plateau. The end-tidal CO2 value displayed on the monitor is considered the value taken at the patient's end exhalation. Phase 4 is the inspiration, marked by the rapid downward direction of the capnogram. This downward stroke correlates to fresh gas, which is essentially free of carbon dioxide that passes the CO2 sensor during inspiration, except during rebreathing. Now that we've looked at a normal capnogram, let's look at some abnormal ones. There are many clinically significant events that you can detect from the CO2 waveform. If the ET tube is in the esophagus, either no CO2 is sensed or only small transient waveforms are present. Often, because you bag the patient with a bag mask resuscitator prior to intubation, there will be a small amount of CO2 in the esophagus. Additionally, if the patient took any carbonated beverage prior to being intubated, CO2 will be present in the stomach as well. After several breaths, that CO2 will be washed out. After 3 to 6 breaths, if the ET tube is in the esophagus, little or no CO2 will be present. What could be going on here? We can see a gradual increase in CO2 on the capnogram. Hypoventilation will usually result in an increased end-tidal CO2. Causes of this might be a decreased respiratory rate due to drug overdose, a decreased tidal volume, an increase in metabolic rate, or a rapid rise in body temperature or hypothermia. Capnography is an excellent tool to determine the severity of such an event. A typical waveform shows the loss of the alveolar plateau and an elevated end-tidal CO2 value. This capnogram shape can be caused by obstructions such as a partially kinked or occluded artificial airway or the presence of a foreign body in the patient's airway. If all of your patient's sample is not reaching the monitor because of a leak, their end-tidal CO2 reading will be lower and the capnogram will be dampened. Possible causes of this would be a deflated or ruptured ET tube cuff, an artificial airway that is too small for the patient, a leak around a mask, or a leaking bag valve mask. When a leak occurs, a distinctive capnogram will be displayed. The alveolar plateau is missing and the downward slope has trailed off. There are 2 types of capnography monitoring in use today, mainstream and side stream. Zoll is the only company that provides both on one defibrillator. With mainstream capnography, the sensor with the airway adapter is placed directly in your patient's breathing circuit in between the intubation tube and the bag valve mask. As your patient exhales, their CO2-rich gas passes through the airway adapter where it is measured. As the mainstream sensor is not in direct contact with the patient, it cannot be contaminated by moisture or secretions. If the mainstream airway adapter becomes contaminated with secretions, water, or by an aerosolized medication, it can easily be removed and replaced. Mainstream sensors have a very fast rise time, which allows the sensors to measure CO2 levels accurately in all patients, including neonates. Unlike older versions of mainstream sensors, today's mainstream sensors are small, lightweight, and run on very low power, which eliminates previous concerns that they were too heavy and would drain your monitor battery. Side stream systems are typically used for monitoring the end-tidal CO2 of non-intubated patients. The patient is connected to the side stream module using the nasal sampling cannula. This cannula transports the CO2 sample to the monitor without degrading the sample as it travels down the sample tube. This helps maintain the waveform integrity and provides for more accurate results. Some cannulas are designed to deliver oxygen at the same time the CO2 is sampled, and some allow sampling from the mouth. The typical sample rate range is between 50 and 200 millimeters of mercury per minute. Regardless of the sample flow rate, a portion of the patient's delivered tidal volume is being removed. It's important to monitor the patient to make sure that this removal does not increase the work of breathing. The capnogram waveform appears on the screen after 15 seconds, so you're able to get an accurate measurement and a waveform as soon as you need it. Zoll defibrillators are equipped with both mainstream or side stream options. They continuously monitor carbon dioxide and respiratory rates using a solid-state sensor or module called the Capnostat. For this program, we'll be using the E-Series, but the setup is the same for the M-Series and the CCT. For mainstream, you need to select an airway adapter based on your patient's size, ET tube diameter, or monitoring situation. The airway adapter on the mainstream sensor is attached by aligning the arrow on the airway adapter with the arrow on the bottom of the sensor. Then press the sensor and the airway adapter together until they click. For side stream, you need to select an appropriate patient cannula and plug the cannula into the connector on the side stream module. Turn the E-Series unit to monitor. The E-Series will display a warm-up message for approximately 1 minute. The message will disappear when the sensor is ready to be used. Should the patient's measurement be needed during the warm-up period, the end-tidal CO2 waveform is available on display. Zeroing should be done the first time a particular sensor or module is attached to the E-Series, or when changing adapter sizes, such as changing from an adult to neonates using mainstream. To zero the sensor, press the parameter soft key, select the end-tidal CO2 menu item, press enter, press the zero soft key. The E-Series zeroes the adapter and displays the zeroing CO2 adapter message for 15 to 20 seconds. The unit displays the zero done message when complete. The compensation soft key provides compensation for elevated levels of oxygen, 60% or greater, and for the presence of nitrous oxide or both. To do this manually, press the parameter soft key, select end-tidal CO2, press More, press the compensation soft key. This can be set to default to O2 in the monitor configuration. We've covered several scenarios where capnography has become the standard of care in EMS. Using capnography in the pre-hospital setting will have an immense benefit for a wide variety of your patients. Bringing this technology to your agency will have an immediate impact on your patient care. You can verify ET tube placement, document and track trends, and continuously monitor your ventilation and perfusion status. In summary, if you're using capnography, keep doing so. If not, it's time to get started.